Hello, everyone. I'm Lillian Cow, President of Ifso, and I would like to extend a warm welcome to all of you who have logged in on the first joint Ifso World Obesity Federation multidisciplinary webinar. Today, we have a multidisciplinary team to discuss a couple of cases on how to manage patients with obesity. Firstly, I'd like to thank the World Obesity Federation for agreeing to join us for this webinar. Today on this panel, for this webinar, I'd like to welcome from the World Obesity Federation, Donna Ryan, who's the president of the WOF and Professor Emerita at the Pennington Biomedical in Baton Rouge, Los Angeles. Donna is an obesity medicine specialist and will give you her viewpoint as an obesity medical expert on the cases presented today. We also have Rachel Sprague, based in Worcester, UK, who is an obesity educator and a clinical champion for nutrition for health, and will give you her viewpoint and perspective as a general practitioner working with obesity. Donna and Rachel, I thank you for joining this webinar with Ifso. From the Ifso expertise, I'd like to acknowledge Mary O'Kane, Chair of the Integrated Health. Mary is one of our leading nutritionalists and is based in Leeds, United Kingdom. We also have Casey Goodpasture from Cleveland Clinic, Ohio. Casey is a psychologist who works with the Metabolic and Bariatric Institute. Mary and Casey, thank you for joining us for this webinar, and we look forward to your expertise as well. Today, our convener is Ahmad Bashar, who is co-chair of the Communication Committee of Ifso, and he's a bariatric surgeon based in Jordan, and we're presenting the cases today. We also have Dr. Hazam El-Momani, a leading bariatric surgeon based in the Emirate of Abu Dhabi, as our fact checker. So without further ado, welcome everyone, and I will hand this webinar to Dr. Bashar.
Thank you, Dr. Cal, for the kind introductions. And this is our first MDT meeting. Hopefully everybody can join in, chip in, and let us know how we did. I'm gonna just launch the presentation. So this is a new initiative, so would like everybody's feedback. As I said, our multidisciplinary team is consisted of Dr. Lillian Cow, our surgeon today, president of Ifso, and our bariatric specialists, Professor Donna Ryan, and as well as the integrated health specialist, Mary O'Kane. Dr. Rachel Sprague from the World Obesity Federation is a general practitioner, just like Dr. Cow, and Dr. Casey Goodpatch. My friend Hazem El-Momani will be the fact checker, and he's the chairman of the Communication Committee of IFSO-MENA, and I will present. If we could launch the first poll, just to see what the practices are worldwide. What does your practice consist of? And you can choose more than one. And I'll start the discussion. You know, in general, the trend, you see surgeons practicing alone, obesity specialists practicing alone. And I'll start with you, Professor Ryan. How do you see the integration between both practices and integrating other specialties on board to tackle obesity?
Look, it's a team sport. We absolutely need a broad spectrum of healthcare practitioners if we're going to do optimal management of our patients with obesity. You know, one of the things where I work at the Pennington Center that we've been very strong in psychology, in nutrition, in medical aspects of obesity management, but only now have we integrated bariatric surgery. So we just recruited Phil Schauer to Pennington, and he is building this bariatric surgery program. So I feel finally like we're playing with a full deck of cards. You know, it's really not, managing patients with obesity is really not something that one practitioner can do alone. It takes a team. What do you think?
I think so too, as well. Let's ask Dr. Cow, from a surgeon standpoint, do we integrate obesity specialists as much?
Definitely. I'm a bariatric surgeon, but I cannot do my work on my own. I'm good at what I'm doing, but I need a multidisciplinary team to look after the patients. So I definitely prefer a team with various expertise to help the patient's journey. I think that's very essential.
Okay. So, you know, there was a technical issue that was sent to us by my co-chair, Abdurrahman, that Paul, we could select only one, but, you know, 43, I guess, of our attendants are surgeons and 35 are dietitians, and obesity specialists are 8%, and nurse practitioners are 8%, psychologists are 6%. But we'll go to the presentation of the cases, and hopefully we'll do a better job with the choices next. So our first case is a 37-year-old female who actually weighs 80 kilograms with a body mass index of 32, almost 33. And unfortunately, she was presented to recently divorced with multiple history of abortions. She has type 2 diabetes for the past 7 years and remained on insulin throughout her marriage for easier management while trying to get pregnant. She was on oral hypoglycemics later after the failed attempt and getting divorced, unfortunately, and she does not have any complications regarding her diabetes. She also has hypertension that is controlled on methyl-dopa and hyperlipidemia on Lipitor. And the one striking feature upon seeing her is her truncal obesity, mainly. Her initial workup, as you can see, lots of lab tests, but to note, her diabetes is not very well controlled at 7.4% of hemoglobin A1C, and her hyperlipidemia, especially the triglycerides, are way elevated. As you can see, it's depending on the units that you use, as well as the cholesterol is high. The rest, low ferritin on her nutritional workup, and the rest seem to be uneventful or within normal limits. So we'll take this discussion one discipline at a time and start with our obesity specialists, and start with, if you're seeing this patient for the first or as a follow-up to her medical issues, how would you initiate the discussion on weight? And I'll start with you, Dr. Pryke. I know you're an obesity champion within the general practitioners. So how do you approach these patients?
Okay, well, I think that's a very good starting point. And I think raising the topic of weight is something that many health professionals do feel a bit anxious about. But in fact, most people who have a health concern want to talk about it. What we don't want is to convey judgment in the way that conversation opens. So just asking about feelings or asking permission are really good entry points. So for example, would it be okay if I talk to you about your weight today? Or how do you feel about your weight today? How is it going with your weight at the moment? Is that something you would like to talk about? So making sure that it's an invitation to talk, as opposed to I've already cast my judgment and I'm going to talk to you whether you like it or not. So that's a really important thing. And the other really important aspect, patients will often have lots of health problems. What's the priority for that patient today? Is it actually their weight? Is it their comorbidities? Might it be something psychosocial? Is it other things? So deal with the patient's own agenda first before we perhaps bring in weight into the discussion, where it may be hugely relevant.
So you've got the patient comfortable discussing the weight problem, and you see all these medical problems on board. How do you approach this patient medically, and how do you optimize her from a medical standpoint? Professor Ryan or Dr. Pryke?
Rachel, maybe I'll start.
Okay.
So when I see a patient like this, the first thing I'm thinking is what is her health risk? What is the stage of her obesity? And so, I think one good thing that's happening in obesity management is that we're moving away from just characterizing patients by BMI alone. BMI tells you something about body size, but it does not tell you where body fat is located. And this patient, we already have a clue, has central body fat distribution. And she also has what in the United States ACE would call stage 2 obesity. She has type 2 diabetes. She has one of the complications of obesity. So the assessment part of obesity is what I'm doing right now in evaluating this patient. And so my assessment is that she has type 2 diabetes, one of the comorbidities of obesity. She has central body fat distribution, and I know that she's at high risk. Rachel, would you add some comments to that?
Yes, I would. I think it's really quite important when we meet this lady, we recognise that she is somewhere on a long journey, a long continuum of weight issues. And I think when we pitch in with our one-off conversation, it's important that we factor in where has she come from, where does she want to go, where are we now on that weight continuum. So I think it's very valuable to find out a little bit about what has she tried before, what are her what are the areas where she feels she would most like to work next, so that we can actually find out what help does she really want, as opposed to there are set options that I could throw at her. What's actually most appropriate? So I think that fact finding is a really crucial part of the conversation to work out how we can bring the opportunities to somebody in a positive way.
Yeah, so the assessment is not just, what's the health risk assessment, it's also the assessment of her lifestyle and her weight history. Those are both two very important areas that we have to explore with her.
Definitely, and we'll get to that. But I think if you look at this patient from a medical standpoint, and the fact that her triglycerides are, elevated, way elevated, and her lipid status is, sort of screams at you, how would you prioritize your approach? Would you tackle that issue prior to discussing the long journey, because this is an acute event in this patient history?
Well, Ahmad, I think you have to do both. I mean, so one thing that's important is to establish that relationship with the patient that's going to be a long-standing relationship. This is a chronic disease that we're dealing with. It's not something where we have to do everything on the first visit. So yeah, the priorities with this patient are to get better control of her lipids, to get better control of her glycemia. I mean, those risk factor management things are something that we do sort of automatically. But at the same time, we know that the pathway to better health and better diabetes control and better lipid control for this patient is going to be through better weight management.
Okay, great.
If I could add, I think it's really important to assess to understand assess her understanding of how much her weight is impacting on her health. That's one important concern. But I think it's also important to bring in a sense of optimism. I think many of our patients, when we see them, are feeling quite defeated. They feel as though nothing has worked. So we can help to try and make sure there's a very positive element to the way we move the conversation forward and introduce different treatment options. That optimism and hope can be very valuable.
Great. And now that you stressed that the fact that it's a long journey and it takes more than one visit, you know, from a medical standpoint, we hear a lot of, you know, backfire on weight loss in diabetics, especially. There are two studies that I know of, which Dr. John Dixon always talk about, as far as higher mortality in patients with diabetes when they lose weight at a lower BMI. Do you note that in your practice? Do you discuss that with patients or no?
Ahmed, this is not something that I discuss with patients. Do you?
I don't. Personally, I don't. Although the evidence is within randomized controlled trials, and the meta-analysis was done within randomized controlled trials, it's we don't have a lot of excellent evidence. The look-ahead study would talk about a better outcomes with significant weight loss. But I wanted to see you from your standpoint, from the medical standpoint, because you know we get different opinions from different experts.
Yeah, you know, I think that patients with type 2 diabetes who have lower BMIs are different. They're different than, you know, the type of patients that we see in the U.S. where, you know, the average BMI in our diabetes patients is well above 35. And so this patient is on the lower end. And especially when we see patients with BMIs under 30 with type 2 diabetes, those patients are slightly different. And, you know, even in look ahead, we were able to demonstrate that there were health benefits to that group of patients who had BMIs under 30. You know, in look ahead, we actually had some patients who had BMIs under 25. So the Asian patients that we included in that study were allowed to have BMIs down to as low as 23.
And Dr. Proik, from your standpoint in the UK?
I think, again, it's important to individualize that sense of what personal effort results in. And I think, obviously, we've got some studies that show that for each bit of effort that you put into losing weight, even if it's temporary and there may be weight regain, we can see some metabolic advantage from that. And I think sometimes that's an important aspect to helping to combat that sense of there's no point, I've tried it before and nothing works because I may well regain my weight. So I think, again, trying to help to understand that there's a motivational drive that we're working on, as well as an effort right now sort of aspect to it. So I think, again, it's that sense of instilling hope in people that each bit of effort, each time is valuable.
Great. And what are the options for medical weight loss in this patient?
Well, I think that, you know, the decision about the treatment plan for this patient is one that's shared. It's shared between the patient and the healthcare provider. So establishing that relationship and grounding that is something that's important. But look, we have a whole tool of options for this patient. There are things that we can do in the medication management that can that can help her, I believe, with weight loss. She's on a sulfonylurea. If we adjust that, we can maybe get some weight loss just by taking her off of that alone. By adding a GLP-1 analog, we may be able to get some additional weight loss. And those are things without that are involved just in diabetes management that may produce a healthier lifestyle. But we also need we need to look at what's going on with other factors that may be driving weight in this patient. What's going on with her sleep habits? What's happening in the stress department? Do we need to work on stress management in addition? So before we even enter into talking about diet, physical activity, medications that may help weight loss, the other tools in our toolbox, bariatric surgery. Before we go there, I think we need to establish that relationship with the patient and get her a bit better controlled in terms of her lipids and her glycemia.
Great, and you raised a great point, Professor Ryan, the sulfonylurea fact. So if you can explain to the audience, what do they do and how do they promote weight gain, and how successful is just taking the sulfonylurea out of the equation in achieving weight loss in your practice within your patient population?
Yeah, so sulfonylureas are insulin and other insulin secretagogues, and insulin are powerful stimulators of food intake and promote weight gain. So patients on sulfonylureas will gain weight. I think there's a great deal of variability as to how much an individual patient will gain, but we can often get improvement in weight just by removing that driver of weight gain. So switching the patient off of sulfonylurea and onto another medication that's more weight neutral or that actually promotes some weight loss is one of the tricks of the trade. So the medications in diabetes management that promote weight loss are the GLP-1 receptor analogs, pramlintide, and the SGLT2 inhibitors. The DPP-4 inhibitors tend to be weight neutral. Metformin can produce some weight loss, particularly if we can get the dose up to higher levels. You know, in the DPP study, patients were followed for 10 years on metformin, and those patients who were adherent to their dose of metformin achieved and sustained about 5% weight loss over 10 years. So I think we need to, whenever possible, try to encourage patients to get to the highest, up to 2 grams of metformin a day for that weight loss benefit that it can bring. But you know, patients sometimes have difficulty tolerating metformin. It's associated with diarrhea. If we use metformin extended release, we can get more. We're less likely to have the diarrhea, and patients are more likely to be able to tolerate it. So if we can get patients up to 2 grams of metformin a day, that's also pretty good for helping to achieve and sustain weight loss. So you know, all of our diabetes associations promote a weight-centric approach to diabetes medication management. And we all need to be looking at the weight profiles of these medications we're prescribing for diabetes. So avoiding sulfonylureas and moving towards those medications which are weight neutral or promote weight loss is the recommended strategy.
Great. And Dr. Pryke, within your practice, if you see this patient, what would you offer them from a medical standpoint?
Well, I think as Professor Ryan has explained, that there may be some medication changes that are appropriate. It can be difficult when we've got patients who generate side effects from their different medications. Sometimes it's worth exploring back what people tried before and the real reasons why they may have changed. There may be reasons that could be overcome. So we may be able to go back to metformin, for example, if if we feel the side effects perhaps weren't genuinely all attributed to the medication. So it might be worth retrying things that were tried a long time ago. But I think it's also important to keep the conversation broad. Medication clearly is a very important aspect, but we don't want to just focus on that. We want to make sure that the patient is encouraged to think as holistically as possible about all of the lifestyle approaches that also support the effects that we get from medication. So, for example, should we also be thinking about pain control to help people be able to exercise more, for example, to other barriers that could practically be overcome that can help patients to feel that they can engage better? Perhaps is their compliance an issue? Are there issues about affording drugs? Is there, should we be thinking more about making sure that they've got a good dietary understanding so that our medication that we prescribe can have a good chance of producing its maximal effect? These things all work together synergistically rather than independently as an isolated factor.
And those are great points that you raise. And we talked about counseling patients for bariatric surgery, and within an MDT, what are the discussion points that you raise prior to advising a patient like her to undergo bariatric surgery?
Well, let me start. I think with this patient, I feel somewhat of a sense of urgency because of her age. She's in her 30s, right? What is her age?
Yes, she is.
Yeah, she's in her 30s. And so she's got a long life ahead of her. And so this is a patient that I think really deserves an effort at trying to get her diabetes under optimal control and maybe even into remission. We don't really know what this patient's beta cell reserve is. Even though she's had diabetes for 7 years, she's been on insulin primarily because she was trying to get pregnant. So we don't really know what the patient's beta cell reserve is. She's young. I feel an urgency about trying to optimize her therapy. So I think in my discussions with her, I would be really talking to her about let's really try to make an effort at achieving weight loss to get optimal control of diabetes, optimal control of lipids. Let's be replacing that iron. Remember, the ferritin was very low. Let's see if we can't really get you in optimal health. So as part of that, bariatric surgery would be on the table. So I would be laying out as an option for this patient an intensive medical approach and bariatric surgery as an option. Rachel, what do you think?
Well, I would agree. I think once again, if we're starting to raise the issue about moving towards bariatric surgery, which may well be relevant for this patient, we've really, certainly in primary care, we have a really important role to start helping patients think about finding information for themselves. There's a huge motivational requirement for patients undergoing very restrictive surgery that has lifelong impacts. So we want to make sure that we are making sure that the most appropriate patients who can manage, who can cope with bariatric surgery are the ones that we signpost in that direction. So as a first step, I would usually ask patients to find out a little bit about themselves. So from my point of view as a health professional, it's important I help patients find reliable information about surgery, perhaps the most up-to-date information, because let's face it, bariatric surgery sort of evolution has been very significant in recent years. So are patients able to get up-to-date information that will help them to understand the all of the essential information that can help them make the right choice? So I think that's a very important aspect for us in primary care, to begin that conversation with fact-finding as part of assessing the motivation of the patient. If the patient doesn't even want to find out about it, we're probably not going to be right in referring.
You know, in the States, we have informational sessions that I will refer patients to. So like our bariatric surgery teams will put on a group session, and it's not intimidating. It's a good way for patients to go with other patients and ask questions and learn about what bariatric surgery really is. And so I'll frequently refer patients to those. I think they're a good resource. Do you have those?
I think there's probably a huge across the world, isn't there, in terms of how patients can access sort of pre-operative information. And yes, support groups are really important. I think we have to be aware that there can be misinformation, and sometimes we might need to pick through some of that. So false hopes, the expectation that it's a quick fix, those sorts of things. I think we can have very supportive conversations about that are very valuable.
Right, and those are all great points. And you know, us surgeons, we always try to press towards surgery. But you know, one of the tools that have been available since November is the risk assessment, the long-term risk of diabetes outcomes, of medical outcomes versus surgical outcomes, published in JAMA by Dr. Aminian and colleagues in Cleveland Clinic. And you know, one of the tools would be this: Escape Diabetes, very perfectly named to promote to escape diabetes. And if we put the patient score, the patient risk factors, you'll get this, which is medical management, the usual management, the optimal medical management versus bariatric surgery. And in that study, they looked at sleeve gastrectomy and gastric bypass alone. Do you use these tools to sort of convince patients one way or the other?
You know, I use a tool in the United States that was developed by the Geisinger Health System, and it's an app. So it's a smartphone app. Unfortunately, I don't think you can download this in other countries. It's only downloadable in the United States, but it's very similar to what the Cleveland Clinic has done here. And what Geisinger did is they used their own database to construct a similar algorithm like this. But that app also has other things. It has patient stories, and it's really done in a way that promotes health literacy. So there are very simple explanations, and it provides great information for patients who are interested in bariatric surgery, who want to learn more about it, and it does it in a way that is accessible, and it's also reliable information. So I think these things are great. I don't know how available they are around the world, but in the United States, it's something that I find very helpful.
Dr. Pryke?
I think that there are various different tools. I haven't used this particular tool that's there, and I think it looks really interesting, and I will certainly look at that. I tend to find, from my point of view, because I'm involved in, I suppose, that baseline assessment, just working out what's really important to the patient. How I would be wanting to know the patient's sort of priorities. What's their biggest driver? Why are they contemplating, this major sort of life-changing surgery in terms of their long-term eating? To see that, to double check that their motivational drive is genuine. So So I would want to make sure that they understand that these are the sort of metabolic benefits, the impact on their comorbidities, so that they've understood what those are. But it may well be that their priorities are more generic, they're more general than that they just know that that they want to improve their weight because it's really important in general, and they struggled with the non-surgical options. So I think it's any of the tools that help understand that motivational drive will be very, very useful.
Great. And, you know, we'll complete the patient's story now and go to Mary. Mary, I know you have webcam issues, so you'll be talking to us behind the scene. And
I think
you
I'm
know,
showing now.
oh, you are? Okay, great.
Yeah.
I can't see you because of the presentation, but it's great to have you. So this patient's weight history, her maximum weight was 85 kilograms, which made her maximum body mass index almost 35. That was 3 years ago. And her lowest was 72 with aggressive exercising. And at that time, she was on Atkins diet. She unfortunately regained to 80 kilograms and now on intermittent fasting. And she's trying to avoid Atkins diet with the hyperlipidemia and the high triglyceride issue that she's having. She generally eats beyond satiety when stressed, and however is very compliant with avoiding sweets with her diabetes. And once we did a body composition analysis, and you can see the waist hip ratio and a lot of truncal weight, and her excess weight is 19.7, and if you take the truncal weight as almost 18 kilograms of those, which is quite high. So what is your strategy when seeing a patient like this?
I think, as already mentioned by Dr. Pryke and Professor Ryan, it's actually getting to know where the patient's coming from. The history of weight loss and history of weight regain is really normal for many people. And I would say that most of the people I see I'd class as very successful dieters, but the difficulty can be in actually maintaining that weight. So I think patients will have very different views of their journey. They may be quite resistant to seeing a dietitian because they've done all that before. So it's actually really understanding where the patient's coming from, trying to develop that rapport, really listening to the patient's story and seeing what's important to them.
Great. And what are the goals that you usually set up to patients to help them lose weight?
I think again, it very, very much is dependent on the patient. So with this patient, she's got a long history of dieting. She's currently on the intermittent fasting, and I'd be wanting to know what's worked well for her in the past, what doesn't work, and also what her expectations are about weight loss, the rate of weight loss, and how much to lose. Because often people are quite disappointed of what they've achieved, when in fact they've actually achieved a huge amount, but they think it's not quite good enough, and that causes them to give up. If she is following the intermittent fasting diet and that's actually working for her at the moment, we'd carry on. But I'd be also looking at what other factors are going on in her life. You've mentioned that earlier that she's divorced. Is she working? Can she afford to eat properly? Does she work shifts? And then with intermittent fasting, how is she doing it? And what's her understanding of intermittent fasting? Is she having long periods of starvation? Is she then overeating to compensate? So also looking at the quality of her diet, because she's had a low ferritin in the past, and is her diet a factor? It might not be, but just really trying to understand the patient's story, and then together look at what her priorities are, and then try to agree goals together. But I wouldn't set them for the patient. We'd actually work through that together, and what I'd be trying to focus on is making sure that they're realistic and achievable.
Oh, great. And if you're going to set a plan to achieve the goal. How structured is your plan, and do you provide certain targets or certain follow-ups before you actually say, hey, this is not working, let's try something else?
Yeah. I mean, I'm fortunate that I work in a medical obesity clinic and we are able to see our patients fairly regularly. We also have the ability to see them, offer them group sessions, and we have access to a physiotherapist as well. So very fortunate in that. So again, agreeing with the patient, what is the most important to her? And then actually looking at what the barriers to achieving those goals might be and how we can actually work together to do that. So sometimes I might have student dietitians with me in clinic, and they might be very surprised that we actually spend very little time talking about the diet itself. We end up spending more time about what are the barriers to change, what's going on at home, what's going on with the children, and how we can actually help them to move forward. So I think it's about making sure that patients have that support and giving them access to any support network that's out there. So if our patients want to go to commercial swimming groups as well as attend our clinics, that's perfectly okay, because sometimes for patients it's actually getting support from others that are going through a similar journey to them. So it's about making just available a wide range of options to help the patient.
Great. That's a perfect practice to be in, I guess.
Yeah.
We're not perfect, but we try.
That's good. And at which point do you say this patient needs more than just dietary measures?
Yeah. Again, from the medical obesity clinic, we're very, very fortunate that the patients I see are also obviously an obesity physician, maybe not quite as regular as me. We have access to mental health team, and in our clinic it's actually liaison psychiatry, but also through their access to behavioural therapy, access to CBT. So as a team, we will review patients and we'll discuss how patients progress, and as a team maybe discuss when they maybe need more mental health intervention or physiotherapy or that type of thing. But the decision about needing more, because we won't just be doing the diet, they'll be having the obesity physician input and everything else. It'll be decision as a team is when do we move the patient on to the next stage, but also making sure, as has already been said, that if we are making or suggesting that bariatric surgery would be the best treatment option, is ensuring that the patient has a really good understanding of what that is, what impact that's going to have on their diet, on their nutrition, and also has the opportunity to talk to other patients who've had that, because for some patients it's definitely the best option, and other patients might decide actually that's not for me just yet. But it's enabling the patient to have all that information in which when they discuss it further they can make an informed decision about what's best for them.
Great.
Yeah.
And when you say, let's say you're within the MDT team and you're functioning within the MDT, so what are the points that you raise prior to recommending anything from a nutritional standpoint in this patient, Mary?
Yeah, again, it would probably be a team decision to move forward, but as a dietitian, I'd be looking at asking if they've considered surgery. Quite often, because our patients come into the medical obesity clinic, we've already talked about the range of options that might be available to them anyway. So they may have come with a view that they're working towards bariatric surgery, or for some of them, they're really not certain. So we will raise that several times throughout the periods of times that we've seen patients. So it's quite often not a new topic. And it's trying to make sure that the timing for that discussion is right for the patient as much as anything else. So it might be something we've actually talked about several times with the patient. We wouldn't necessarily be trying to coerce the patient into having surgery. It's got to be their decision as well, but making sure they've actually got that information to make the right decision for them.
Thank you very much, Mary. And we'll complete the picture even more with Casey. So thank you for being with us, Casey. So as you know, this is the patient is divorced. She had a rough marriage due to weight and several abortions. She actually had a previous history of sexual abuse by one of her family members that resulted in their parents, in her parents separating. And she presented with an overprotective mother. She's the oldest of two siblings. She has a younger sister and a brother. So from the psychological point of view, what are the important points that you evaluate in this patient prior to any intervention?
Well, lots of them is actually, there are pieces that overlap with what others have talked about so far. We begin by talking about the goals and understanding of whatever weight management approach that the patient is taking, whether it be medical or surgical, and ensuring that they have realistic expectations so that they're not setting themselves up for feeling like they have failed to meet a very high bar. We also talk a lot about eating and weight history, the things that worked, the things that didn't work, and do a very thorough assessment of eating disorders, including binge eating, night eating, and graze eating. Mental health history, including current symptoms, past symptoms. We do talk about abuse history, as well as substance use. We talk about the social aspects, the level of social support, like in this patient, seems to be lacking, being that she's divorced. And we talk about various stressors that are going on and what they are using to cope with their stress presently.
Great. And, you know, in this patient in particular, what are your concerns?
I think the biggest concern is that the underlying challenge of her overeating, if that's not addressed, then regardless of what treatment approach she chooses, the outcomes of that are going to be compromised. So we want to look at that stress and that eating past fullness and seeing if we can rein that in addition to moving forward with these other kinds of approaches. And as I mentioned before, the low level of support in her household as well. Does that affect her eating habits? Any relationships that she is in, is there any sabotage that's going on, intentional or unintentional? As well, in terms of the abuse history, sometimes we find that patients who have these histories, particularly of sexual abuse, do feel more vulnerable or exposed when they're in smaller bodies because they begin to get more attention from other people. And that can contribute to a post-traumatic reaction or other kinds of mood changes and some mixed emotions about losing weight. So that too might be something that we would explore.
Great. And, you know, from those concerns, within those concerns, how do you recommend preparing those patients, and what are the goals of any therapy that you offer?
So with the role that I have within weight management, we focus mostly on the weight-related issues, but when there are other underlying mental health concerns that really seem like they're getting in the way, so if there's a lot of depression, anxiety, post-traumatic stress, then we refer patients out for some additional kind of ongoing therapy to focus on those kinds of concerns as well. We may work either with our obesity medicine specialists to see if there's a medication that might help both with mood and weight management and consider that. Or they may have an outside mental health prescriber that we could work with and consult with on that. Some goals would be helping her to feel safe in a smaller body if that's one of the things that's contributing to her motivational difficulties, and really helping her to develop some non-food soothing strategies. We may consider doing some kinds of brief group treatment, something we rely upon a lot at the Cleveland Clinic to address her emotional eating as well.
Great. And all these factors, when do you give the green light from a psychological standpoint within an MDT to do certain therapy versus the other?
Well, usually patients they already have, by the time that they get to us, a pretty clear vision of what they would like to do. Every now and then I come across somebody who's ambivalent and we kind of work through that together. We might consider what are the risks of having surgery versus the risks of not having surgery, for example. But I don't like to think about the role of psychology as providing a green light or a red light or any of those. I don't like to see us as gatekeepers, but more as a supportive role. Now, with bariatric surgery, there are some very clear contraindications that we have to be aware of, things like active psychosis and so on. But for the vast majority of people, they're going to get to surgery if that's what they want to do. It's just a matter of making sure that we have done everything we can to try to prepare them to get the best outcomes from that. So within the multidisciplinary team, I think about nutrition, helping more with them knowing kind of what to do. And then if they have trouble with, okay, they have the knowledge, but how do you put that into practice in the context of these stressors or social aspects? Helping them in psychology to figure out the how, narrowing the gap between knowing what to do and doing it. And we do try to balance out as well, wanting to prepare patients as much as we can so we can optimize their outcomes with not wanting to cause undue delay with whatever treatment that they're doing. And so that's why brief forms of treatment can be really helpful. Brief CBT is something that we use a lot.
Great. Thank you, Casey. And thank you for correcting me on the green light issue. I know we complete each other, and we're there to support patients for sure. And Dr. Cow, we come to the surgical aspect. And, you know, us surgeons, whenever we see a patient, we're more thinking of surgery and preparing for surgery. But within your team, when does the surgeon see the patient?
Well, I think in a bariatric surgical team, it is the surgeon that leads the team. After all, it's a surgeon that the obese patient comes for a surgical treatment. However, I believe that the success of the whole weight management program will benefit from a multidisciplinary approach. And this input, I believe, can be in two phases. One is the pre-operative phase, which is then continued into the post-operative phase. For example, in the pre-operative phase, I believe there's a benefit to firstly assess the suitability of a candidate from a mental and psychological state. It's also beneficial to educate the patient about the dietary protocol, and this may include, from a dietary point of view, a pre-operative liver shrinking diet, as well as educating the patient about their dietary restrictions after surgery. And this could include volume control, nutrition, and the role of multivitamins. In the post-operative phase, again, a multidisciplinary approach is very helpful. And this may include mindful eating to the patients, volume control, food choices, and strategies to help their eating habits, in particular, emotional eating behavior.
Great. And in this patient, I know we had a question on determining her candidacy for surgery or not. I know there's a lot of you know, insurance companies that won't cover bariatric surgery for BMI less than 35. This patient is diabetic, and by all you know, recommendations and international guidelines would state that she is a candidate. But what do you think?
I think in the simplest criteria to determine if the patient is a candidate is using the NIH criteria, which is a BMI. So greater than 40 or greater than 35 with comorbidities. But other ways of measuring whether the patient is suitable is their motivation for surgery, whether they're ready to make the changes behaviorally, what the expectations are, and whether they understand what the surgery is all about in terms of food restriction, behavioral modification, and whether they're prepared to incorporate their nutritional and lifestyle changes. Also importantly, as Casey and Mary and Rachel and Donna have said, is that whether this patient's got the appropriate social supports, whether they've got the appropriate home and work environment, whether their family dynamics support them having surgery and making the appropriate changes, you know, who cooks at home, if there's the sabotage in the family that may help them in their journey. And of course, you know, their mental status. In surgery, we always have contraindications, and to us, we talk about the contraindications to bariatric surgery, which would include uncontrolled psychiatric disorder, suicidal attempts, active substance abuse, whether they're actively smoking, whether they're on steroids, whether they're mentally limited in their understanding, or even a simple thing like uncontrollable inflammatory bowel disease. So these are the things that I like to go through when I see a patient to see if they're suitable for their surgery.
Great. And those are all important points in a holistic approach. But, from a surgical standpoint, what are any additional workup that you require prior to recommending a procedure or to help you in making a decision towards one procedure or the other?
So in addition to the input from our multidisciplinary team, I like to recommend that my patients all have an endoscopy. So for example, if having a sleeve, I like to make sure that, I like to assess their gastroesophageal junction, whether they have a hiatus hernia, whether they have reflux disease, or whether they have any ulcers. And for patients with gastric bypass, I know that once I've done the bypass, no one can ever look into their stomach again. So an endoscopy is a baseline assessment of the health of their stomach. If they do have symptomatic reflux, then I sometimes consider a pH manometry to assess the function of their esophagus. I also like an ultrasound to look at all their solid organs in their abdomen to make sure that I do not get any surprises when I go and do their laparoscopy and their bariatric surgery. And of course, from a nutritional point of view, just some baseline bloods to look at their nutritional status in terms of their minerals and vitamins.
Great. So there are several tools that are out there from a surgical standpoint to help decide a procedure more rather than the other. And one of them is the individualized metabolic score or versus the risk benefit calculators like the one in MBS Equip. Do you use those routinely to guide you to determine what to do?
I don't use them routinely, but I do use them occasionally. For example, the metabolic surgical score categorizes patients with type 2 diabetes into a validated stages for evidence-based bariatric procedures. So it might help someone to choose their procedure. Quite often patients come and all they want is to lose weight. They don't care about their metabolic status. They don't care about their diabetes or their high blood pressure. But it is useful. For example, the metabolic bariatric, the surgical score looks at their diabetes. They look at the number of medications, whether they're on insulin, duration of their diabetes, their glycemic control. And for example, some of the mild score, we know from the results of the metabolic surgical score that either a sleeve or a bypass would result in good result because it's just mainly based on weight loss. But if it's a moderate score, they might want to have a Roux-en-Y gastric bypass. And on the other hand, if they have a severe score, we know that just weight loss alone may not be enough. And then the other one you touch upon is the MS Cube, which is a risk-benefit calculator put out by the American College of Surgeons. This is a calculator based on a large number of patients, looking at their 30-day outcomes, looking at their prediction of outcomes. And I think many patients come not really wanting to know outcomes. All they want to know is, does the surgery work for them and whether they will get a benefit. So if they really want to know about their risk calculation, then I will put them through the MS Cube risk calculator. But most of the time, all they want to know is how much weight can I lose and am I a successful candidate?
Great. And within the MDT, how do you see unisons? How do you recommend surgery for this patient within an MDT? What are the points that are for her to recommend bariatric surgery?
So when a patient comes to me, I always value my MDT team for their opinion whether a patient is suitable or not suitable for their surgery. If they raise any red flags, then I will take note of it. But I think this particular patient, it's a good candidate for surgery. And I don't see any red flags from this patient.
Okay, great. And we'll complete the points that we asked about. This is the endoscopy of this patient. And just like you say, if you're operating on an organ, probably it's best to collect more information. And you can see this is the GE junction. There's some esophagitis, and it's labeled as grade B esophagitis. And you can see bile in the stomach upon entering the stomach itself. This is the duodenum. It's a fast-paced endoscopy just to collect all the information that we need. And there's a small hiatal hernia. So grade B esophagitis, small hiatal hernia, bile in the stomach. What would you think if you're going to offer surgery, Dr. Cal?
I think the patient will do well from any weight loss surgery. It's a small hiatal hernia, and I'm very happy to repair the hiatus hernia and then proceed to either a sleeve gastrectomy or a gastric bypass.
Okay, so moving on with the tools, if we put the risk factors, the individualized metabolic score would make her a moderate risk. And in a moderate risk, the advantage to gastric bypass is recommended because of a higher remission rate. So would you agree that you would think more about gastric bypass as opposed to sleeve?
I would give the option to the patient for both, because the patient is 37 years old, so she's relatively young. And if you think she's got about 40 or 50 years ahead of her, she must understand that with a Roux-en-Y gastric bypass, it is a metabolic operation. There are risks of nutritional problems in the long term. So osteoporosis, vitamin B12, iron deficiency, all those things we need to consider for a patient who's relatively young, that they need to think about in their next 40 years of life.
Great.
So Lillian, excuse me, can I ask you something? So
Please.
what
Yes,
about,
Donna.
yeah, what about patients who want to have children? Is there a preference for sleeve versus bypass? For women
Well, I
who want
think,
to have children in the
yeah.
future?
So anatomically, a sleeve gastrectomy is more anatomical. If they move on to a gastric bypass, then they have to understand there are nutritional deficiencies that they have to be very aware of, and particularly in a childbearing age where they may have a number of pregnancies, their nutritional problems may become evident during pregnancy and later on in life as well. So all these things, I think we can work with them and with their obstetrician as well.
So this is the risk-benefit calculator that we mentioned, and it shows the potential complications between band, sleeve, bypass, and DS in any patient. And if you plot the risk factors, it's an excellent tool to use. And it gives you the projected weight loss at 1 year, as well as the potential remission rates according to the MBSA-equipped registry. And you can see all the potential options. But let's move to the audience for our second poll and continue our discussion now that we collected all the information. And from the audience standpoint, listening to all what we said, what would you offer this patient? And you can only select one option. And let's all talk together and see if we can figure this out as a MDT working together for the first time. So what are the points that we discuss to achieve the best possible outcome with this patient. And I'll start with Professor Ryan.
Well, I think bariatric surgery may be in this patient's future, but I do not think this patient has had an optimal approach with lifestyle, psychological therapy, and good medical management of obesity. So that would be my choice. One thing that I think happens particularly with patients with type 2 diabetes, is that we get into this mode of, well, it's a chronic disease and we've got a chronic care model of management. And so there tends to be a bit of inertia, sort of medical inertia about really pushing more optimal therapy. So I feel in this patient a real sense of urgency because of her age. If she were 60 or 70 years old, it would be a different matter. But this woman is in her 30s, and I think we really need to intensify therapy. So for me, of course, I want to try more intensive medical therapy. That's not to say that we aren't going to go to bariatric surgery, because we may.
So, we always think about a window of opportunity and the beta cell function, and you raised that point of being young, and we always press towards surgery, remission, and aggressive therapy. But within this window, so what is a good period of time before you actually say this patient, let's move on to bariatric surgery? Is there a time limit that you put?
Yeah, so you are getting to the weakness of my argument for medical intervention, and that is that we're very good at producing weight loss. We're not so good about maintaining weight loss, and there are multiple reasons for this. And I think our therapeutic approaches we do have ways of doing that, but in practice, we just don't do that so often. So I think that if this patient, I would give this patient a good trial of optimal medical therapy, and I would expect the patient to lose weight and lose weight over 6 months and to maintain that for a year. If that patient starts regaining weight, then I'm really going to be pushing towards bariatric surgery. So I'd say a good 1 to 2 years is all we really, for this patient, is all I would really devote to that. I think if we get better, especially at using medications more for weight loss maintenance, I'll be able to give you a run for your money on medical therapy versus bariatric surgery. But right now, the weak link is our weight loss maintenance. It's not that we can't produce weight loss, is that medically we have a hard time sustaining it.
So Donna, this patient is 37 years old. She's got diabetes, she's got double medication, she's hypertensive, she's got high cholesterol. How much more can you do with her in the next 12 months?
For the next 12 months, I know I can get 15 to 20% weight loss. Now, the problem, Lillian, is sustaining that. But to do that, I have to have a patient who's going to be with me all the way. And that's why I need Casey. Casey's going to have to help me on this. Every patient's journey is different. And we do get patients who are not able to adhere to our medical interventions. So, and so I think for this patient, I need Casey's help in supporting this patient through an intensive medical approach.
I'm happy to help you, Donna.
Thank you.
So let's take the medical approach and move forward a bit. The issue with medical approach and is, you raised it, Professor Ryan, is compliance. But I'll ask Dr. Pryk, when you offer, therapy and medical interventions, what's the fallout of patients? How compliant are they in coming back? And Casey, how successful are you in retaining all those patients within a medical weight loss?
I think that's why we've emphasized so much about the importance of assessing motivation and also understanding that sense of where the patient is on their weight continuum. They've struggled with weight for a long time, and I think it takes a long time to come to a decision that a surgical option is right. So I can imagine that many patients will think about it, feel ambivalent, and have to work through that, and perhaps change their mind quite a bit in the process. So I think it's I think we need to sort of understand that uncertainty and that need to perhaps be given more time to let decisions sort of sink in and eventually to formalize. So I think the psychological assessment for this lady in particular is absolutely crucial. Does she really need to work through a lot more of the psychological burden that she carries before she's in the right frame of mind to be able to move on to this long-term commitment with the surgery?
So I think we're all in agreement that what we don't want for this patient is for well, let's just adjust the diabetes medications. Let's just add a statin. Let's just put her on some oral iron, and let's see her back in 6 months. We don't want that sort of chronic disease inertia. I think we all agree we want to intensify therapy, but I think we would all agree also that what we need to do is lay out the options to this patient and get this patient's input into the decision. So it's not what are we going to recommend so much as we're going to offer a menu of options for the patient, and which one is the patient going to choose.
And also that it's not either or, but more both and. And this period of psychological and behavioral optimization with the medications could be a really good lead up to surgery. So maybe ultimately she doesn't find she needs surgery because she does really well with that. But if she does find that she needs surgery, she's had really, really good preparation because she's been practicing a lot of the lifestyle changes that she would need to be successful with bariatric surgery. And back to the earlier question about how do these patients do with follow-up, the ones that follow up do really well. We have an issue with follow-up though, and if patients are going to have trouble following up for the behavioral and the medical weight management, then they'll probably have issues following up after bariatric surgery too, which would compromise outcomes.
Yeah.
And Mary, from your standpoint and compliance with diet and the difficulties they face, how successful are you within the MDT in making patients follow up as well as sticking to a certain diet versus the other?
I think with the diet, it's always what's best for the patient, because I don't think there's a perfect diet. None of us eat perfectly 100% of the time. And for patients, it's different options. It might be a low carbohydrate diet, it might be intermittent fasting, it might be what they view as a modification of healthy eating. So it's working with the patient as to what they can actually best manage for them and their small achievable goals. But I agree with everything that everybody said. The psychological element is extremely important. Our patients need support. And what we tend to do in our clinic is we might not rule surgery out as an option, but it's actually working with the patient to find out when the timing is best for them. Because it's already been spoken about, it's the fact that weight maintenance is really hard. We know from lots of different studies that if people can eat regularly, try to not eat past fullness, not to graze, not to snack. And we do those things, all of us do those things for different reasons, and it's actually working together to help the patient to move forward. But it's not saying that patient can't have surgery. It's sometimes actually working out when is the best time for that patient. And sometimes we think it's now, but the patient's telling us, no, I'm not ready. So sometimes it's quite interesting. The patient was saying to me, I don't want to go forward yet. I actually want to spend longer with you. I need to actually get this right first. And we've got to respect the patient's decision as well.
Those are my favorite types
Great.
of patients, the ones that have that insight.
Yeah, great. Yes. And they're very good at attending as well. So, yeah.
Yeah. Those are all great points. And the compliance issue, the long-term follow-up, if patients don't see results, that's the most challenging aspect. And that's why I
think we might have lost Dr. Bashir at the moment.
It looks like he's fallen asleep.
evaluating, maybe.
You're back.
I don't know. What do you say? With continued
Oh,
Lost again.
Whilst we're waiting for Professor Bashir to rejoin us, I would like a request to all of the bariatric surgical colleagues out there, when you're writing your discharge letters to your primary care colleagues, please do include training information, guidance about long-term follow-up for our patients, so that we in primary care can continue that long-term support for patients after surgery. This is new, a new area for us, and so we're going to benefit from your guidance as surgical colleagues in putting that information in the discharge letters, so that we're constantly reminded of what good practice is in the long term for that long-term follow-up and support and monitoring for these patients.
That's an excellent point, and I think that's why we should be talking to each other even more in caring for these patients. And I'll go to my colleague Hazem. Hazem, how did we do? Did we mention any wrong numbers? Can you add anything?
It's a fantastic discussion. It's like sitting through a real MDT. Not much to say. I only have a comment to make about the proactive study that you referred to, Ahmed. So the proactive study was a randomized double-blind outcome study published in 2011 in the International Journal of Cardiology. And it looked at patients with type 2 diabetes who've got a history of macrovascular disease. And as you've mentioned, there are lots of people who quote the obesity paradox that came out of this study, because the study had concluded that amongst patients with type 2 diabetes and cardiovascular comorbidity, being overweight or obese, you have got lower mortality when being treated medically compared to patients with normal weight. And they also found that losing weight rather than gaining weight was associated with increased mortality and morbidity. So while this study is a decent study, I don't think it can apply to the case in hand, because as you've mentioned earlier, this lady has got no history of cardiovascular comorbidity. So I think based on the risk assessment that you've done, there's no reason why not to consider a higher risk compared to someone else. The only question I have to raise to you, Ahmed, is considering this lady's young age and her startling lipid profile, has she had any genetic testing for hyperlipidemia and all sort of things? Because she seems to have a whole sorts of metabolic disorders, yet her BMI isn't that very high.
That's one excellent point, although she does not have any family history, but that's one thing to look at within her workup and raise. Do you agree, Professor Ryan?
Yes.
You know more than we do, and Rachel.
I think usually that would be something we would pick up in her general care. I would hope that the family history, that certainly as a young person, if she had a strong family history, she may have brought that up independently. So I would hope as GPs we would have incorporated that into her general care, not just specifically considering her weight, but also in terms of her diabetes monitoring too.
You know, I think this patient exhibits sort of the phenotype of a person with ectopic fat storage. You know, so she certainly has visceral adiposity. She likely has pancreatic adiposity, liver adiposity, muscle adiposity, and epicardial adipose tissue too. So I think she certainly has a phenotype where she stores fat in these ectopic places. And that fat, that white adipose tissue, has a much less, it has a much more unfavorable and lipotoxic profile. So I think it's, we're seeing that lipid profile by virtue of her visceral fat stores and the bathing of the liver by free fatty acids. I mean, so that's certainly a part of this. So genetics is playing a role in this. It's playing a role in where her fat is stored. So even though her BMI is 32, she has ectopic fat stores like the rest of our patients do at a BMI of 50.
Okay, great. And those are all great points that we raised. I know we're beyond our time, and we plan to discuss a second case. Is it okay to move forward for everybody?
I have my coffee. I'm with you.
I'm okay.
Dr.
Let's
Cal,
proceed.
Casey?
Let's go ahead.
Okay, great. So our second case, and we'll be quick, I'll present the facts. A 39-year-old female who weighs 161, her BMI is almost 60. She had a gastric banding in 2013, which resulted in 20 kilogram weight loss, and had a sleeve gastrectomy with removal of the band that resulted in no weight loss, and actually she started to regain weight afterwards. And she has significant truncal and visceral obesity with arthralgia, lower extremity varicosities, dyspnea on exertion, and asthma, but no other associated medical comorbidities. She's a business associate professor. She is single with a family suffering from obesity. She's the oldest of 5 siblings with very supportive parents. She has poor eating habits, continuously snacking on carbs and sweets, and she seems depressed and fixated on failing all surgeries. This is her workup, and you can see slightly, mildly elevated fasting blood sugar. Her hemoglobin A1C is 6%. She has a moderate insulin resistance, slightly elevated liver enzymes, but lipid profile is within normal limits. Borderline uric acid with good nutritional workup, and her TSH is 3.7 almost. And this is her endoscopy. And this is the striking part. This is a fast endoscopy. It's it shows basically a dilated sleeve, but the most interesting part is a huge fundus. And you can actually retroflex and see that huge fundus right there. That was left alone at the time, probably, of the band removal and sleeve gastrectomy formation. And she does not have esophagitis per se. She does not have a hiatal hernia. And you can see on the virtual gastrography that big fundus is laying there. So we'll ask the audience and discuss this case between us. If we can launch the poll. So what do we think? From a medical standpoint, I know she does not have a lot of medical issues, but is there anything that you look at, Professor Ryan and Dr. Pryke?
Well, you certainly demonstrated she has an anatomical problem that needs to be addressed, but she also has some lifestyle, some other lifestyle issues around her diet, and she might benefit from medications too. So
I think understanding her psychological sort of state at the moment and what's most important to her, and how she feels about trying to re-establish sort of a new direction is really important. So I think the psychological input is going to be absolutely crucial for this lady.
Great. Since we discussed the psychological point, Casey?
Yeah, I agree. That's a big piece of this picture. So with her continuous eating, her graze eating, that's a really common contributor that we see to weight gain, and that often the anatomy will stop someone from eating a lot at once, but that feeling of loss of control can manifest in different ways for people. And it seems highly mood related. There might also be some kind of a vicious cycle going on there where she's feeling depressed by lack of weight loss, but the lack of weight loss is worsening her depression, and that's further worsening her eating habits. And so getting out of that failure mindset would be an important goal of therapy.
And the snacking part, Mary, what would you say?
I think adding to what Casey says, totally support exactly what Casey said. The snacking, the grazing pattern of eating, it doesn't matter what type of surgery someone has. If that's not addressed, the snacks, the crisps, the easy to eat foods will always pass down very easily. And what I'd be concerned about is that possibly her fat intake is very high. We know that there's fat malabsorption with that. I know vitamin D levels are very good, but commonly after the SADIS, when it's reported, we see vitamin E, A and K deficiencies, and also I'd be worried about trace mineral deficiencies too. So I'd be concerned that if we don't address the psychological issues and help this person follow a more nutritionally balanced diet, we could end up running into more nutritional problems in the future, which just haven't been picked up yet.
And we see the audience leaning more towards optimizing, and some are offering Roux-en-Y gastric bypass versus one anastomosis versus single. Majority are choosing Roux-en-Y rather than any other surgical option. What do you think, Dr. Cow, with this big fundus and her BMI of 60?
I think this is a very difficult patient. She's obviously an intelligent patient. She's got poor eating habits, and she is probably heading towards a third operation. Looking at a second operation, which was the sleeve gastrectomy, I think that's a technical problem. She has a large fundus, and therefore it's not giving her the restriction that she requires. So before we embark on the third operation, I think it's very important that we have our multidisciplinary colleagues to help her in terms of her dietary input, her psychology aspect, and her daily behavioral changes that she needs to make before she takes on her third operation. This is a classic case of a patient that needs a very good multidisciplinary approach and support.
So we're all in agreement that this lady needs optimization from a habit and behavior standpoint. So, Professor Ryan and Dr. Pryke, what medication can help us achieve some help and to support her in her habit change, feeling less hunger, less snacking, grazing, while we work on the behavior issue with Casey and Mary?
Well, so the choices that we have around the world would be liraglutide 3 milligrams, and in a large part of the world, naltrexone bupropion orally. Because she has this the altered stomach physiology, I would tend to go for the liraglutide, which is given by injection. We do have a small body of observational evidence of liraglutide being given to patients after bariatric surgery, and it does appear to have the same efficacy that it does in individuals who have not had bariatric surgery. So on average, we would expect to see 5, 6, 7% weight loss. Some patients will do better, some patients will not do as well. But we know that it should, if we're going to see results with this drug, we should see it within the first 12 weeks. So we would give a trial of that medication and see if it worked or not. I also would not rule out metformin in this patient. I mean, she does have prediabetes. She does have insulin resistance. And some patients do very well on metformin with a control of their weight.
So with a patient of BMI of 60 and medications, how successful within your practice, Dr. Pryke, are we able to, lower this patient's weight down and help her see some results?
Well, once again, I think it's a case of understanding what is the top priority for the patient and building on that. And sometimes when there is a sense of failure in one area, it's perhaps worth building on a strength in a different area of her health. So she may find that in order to be able to reestablish her sort of her sense of commitment to lifestyle change, that it's worth moving away from weight temporarily in order for her to sort of to regroup and to feel as though there's some positives again. So sometimes just stepping back a little bit, keeping a broader sort of approach to health overall, a much more holistic picture, and working on some of the other aspects that she feels that she can cope with right now, that might be relevant. And then coming back, sort of resetting a new timescale so that we can then start again with the really important aspects of how she can face this battle that she's obviously found so very, very difficult.
I'd like to give a comment about the amount of weight loss with medications. You know, I think my surgery colleagues all want to get 30% weight loss or more. And yeah, that's great. But look, you can get a lot of health benefits with 5% weight loss and 10% weight loss and 15% weight loss. So, and this is true whether your BMI is 60 or your BMI is 30. So it doesn't matter. If we can get this patient down by 10%, I can guarantee you that her A1C will be normal and her fasting glucose will be 80.
And how do we set those expectations and help her with her seeing lots of let's say what she documents as failures? Casey, how can we change her mindset?
Well, I often ask patients, if scales didn't exist, how would you know that you were where you needed to be, and set some more non-scale kind of goals. So certain health markers that she wants to improve or quality of life indicators. And along with the quality of life, sometimes the impairments are more due to patients' own perceptions and internalized weight stigma than it is due to their actual body size. So there might be things that she's feeling very held back in doing in her daily life that she may be able to do if we just work on increasing her confidence in her body image. That's a place we start. We don't say, okay, let's get you to lose weight and then you can go out and live this life that you want to live. But are there things that you're not doing because you're afraid to do them? You're afraid to go to the gym, or you're afraid to go out walking for fear of comments and things like that. And that can help to break out of some of that failure mentality.
Great, and we thank Dr. Pryke. She had to step away. Thank you for taking the time. I know we took a long time, but it's a very interesting discussion, and great to have the World Obesity Forum and such an MDT discussion for the first time within the Ifso platform. So, Dr. Cow, we see all these challenges, but we also see a big fundus, a surgeon who probably did not address taking down the fundoplication, the gastrogastric plication over the band before they actually approach the sleeve, and that's probably the reason why she has a big fundus. How do you decide on moving on, and when do you recommend addressing that point?
I think it's important to work through this with the patient, because you can understand the frustration for the patient having had a second operation and finding that she can still eat, and in combination with her poor eating habits, just cannot get her weight down. So I think in the first instance, getting the whole multidisciplinary team to support her, to know that she's on a journey with good supports, and then to sit down with her and work out what is the best anatomical outcome. Whether it's a bypass or one anastomosis, it doesn't matter. I think the next operation is the crucial operation. We've got to get it right.
Great. So I'll tell you basically what happened with this patient. Let me just move the cameras away. I managed not to move the cameras away, but yeah. Here we go. So she underwent a single anastomosis after preparing her, SADIs with excision of the retained fundus and a long biliopancreatic limb and 250 centimeters. I'll show you the timeline. She managed to achieve 40 kilogram loss, 40% excess weight loss at 12 months. To us, that's pretty decent, but you would expect her to lose more weight. Unfortunately, with resecting that fundus, she developed severe gastroesophageal reflux requiring and controlled by twice daily proton pump inhibitors, and unfortunately started to regain weight with self-blame, hopelessness, depression, emotional eating. And I'll show you the timeline. So this is when she had the gastric banding. This is when she had the sleeve gastrectomy in 2015. And at the time, we didn't have liraglutide. We had only topiramate to offer to patients. We started her on that to help her achieve some control in habits. And we were able to sort of help her plateau a little bit and get to a surgery standpoint. And she lost quite a bit of weight, but starting regaining weight. So this is the complex issue. What now?
I think you've really got to support the patient with psychological issues, the reasons for eating. The SADIS is an extreme procedure in the sense that quite malabsorptive, protein malabsorption, fat soluble vitamin malabsorption. And unless we get it right for this lady, she could run into real problems nutritionally. And I'd be really looking to work with Casey to help this patient move forward and address some of the eating patterns that are going on. Because we do know that grazing, snacking type of pattern of eating is actually not going to give those good results. But the patient is going to have poor self-esteem. There's going to be an awful lot of work and support that this lady needs to move forward.
So, Casey, if you get, such, we always say as surgeons that, those malabsorptive procedures provide excellent results. But if you have, a complex patient that is regaining weight on such a procedure that has a high success rate, then how do you approach these patients in Cleveland Clinic?
Well, I think with this patient, just as Mary was saying, it's about the graze eating that we need to address, and I think the thought process as well. And part of the issue is that when patients are going in for a revision or a conversion, they often expect that they're going to lose more than they did with the primary surgery, and they typically don't, but we don't really have a good way to estimate how much that they are going to lose. And so it begins with the realistic goal setting up front and saying, hey, you're probably not going to lose as much as you did the first time, but what are some non-scale goals that you would like to achieve with that? And looking at this, this graph, she actually did pretty well. And so I would want to work with her on really reframing her own success, because if she keeps getting so wrapped up in I failed or I'm failing or I'm regaining, it can become very much a self-fulfilling prophecy where that is causing her to feel more depressed. And as I said earlier, then she's eating to cope with that. So really helping her to ease up on this fear of regain so that it doesn't keep happening.
So, Dr. Cal, from a surgical standpoint, if we're offering a single anastomosis DS in this situation, what is a realistic expectation per the revision, which is a realistic expectation for everybody in the MDT team that Casey raised?
I think for this patient, I wouldn't offer her any more surgical interventions. I think it's someone like Casey that will have to work with her. And I would rely very heavily on Casey and Mary, a dietitian as well, to get her to where she is. It's not an easy solution because every operation you give her, she's got poor eating habits. She, just needs the support to get her through. I wouldn't rush into another operation.
Definitely. And Professor Ryan, from your standpoint, is there anything else from a medical standpoint that we need to address and offer to this patient?
Absolutely. I'm not giving up on this patient. We know that patients will, that medications work best in combination. So I am going to work on medications to help her with the biology that's driving those poor eating habits, along with working with Mary and Casey on the dietary advice and the counseling. So I do think, if we take a long-term approach for this, we've got medications that can be used in this patient. We've got liraglutide, we can try topiramate again. We've got metformin, we've got pramlintide. There are other medications coming down the road that are more powerful and produce more weight loss than liraglutide. So I'm actually not unoptimistic about being able to help this person over the long term.
Great, and it's important not to lose hope, definitely, within the MDT. Are we ready for genetic screening?
Well, I personally would not advise doing genetic screening on this patient. Depending, of course, on her family history and her own personal history of obesity. If she had extremely severe obesity in childhood, maybe so, but otherwise, no.
Great. And I know we are taking beyond our time, but her metabolic results are definitely better, which is something to look at and promote as a success.
I told you so.
Yeah, definitely. And we've went through the fourth poll, and everybody's agreement that we should optimize her lifestyle. Hazem, well, we went through the discussion. Hazem, how did we do?
Very well, as always, Ahmed. I think in your case, the science was against you, Ahmed. The behavior of your patient was pretty much consistent with what others had reported. Those who carry on to undergo further revisional surgeries, being a second or a third, it's always anticipated that their weight loss is going to be less compared to their initial surgery. In the management of your patient, I would agree, and the science would agree with what the colleagues would say, is that optimal medical treatment and considering medications. I know where you practice, you're quite limited with the options, but you can always consider contacting a friend, as you always do, to send you some of the medications they use in other countries. But other than that, I've got nothing to say, Ahmed.
Thank you very much, everybody. I know we took a lot of time, but it was a very interesting discussion to get your input on those two complex cases within the world crisis that we're living in, and taking the time to sit with us in Ifso. Dr. Cow, and everyone, please, if you have any final inputs, notes.
Thank you very much for including me.
Well, I'd like to thank everyone. I mean, I certainly appreciate the joint effort between the World Obesity Federation with Ifso. This is the first joint meeting, and I think I've had a great time with everyone, and I hope that our attendees have also learned a lot from these two complex cases, as I have. So I thank everyone for their participation. As you mentioned, we are going through a difficult time, and probably in the next few months, we may have to get onto webinars rather than face-to-face meetings. I've certainly learned a lot tonight or today from everyone. So thank you everyone for your input. Everyone be safe, and hopefully we'll do more of this in the near future. And once again, Ahmed and Hazem, thank you very much for your input.
Thank you.
Thanks, everybody. It
Thank
was
you.
a great break from my worries about COVID-19. I had a lot of fun. Thank you.
Yes,
Thank you very
Thank
much.
you, everybody.
And we have to thank Manuela behind the
Thank you very
scenes,
Oh, yeah.
taking the time
Definitely.
within the crisis in Italy. And thank you very much, Manuela.
All right. Goodbye, everyone. Thank you
Bye.
again.
Bye,
Thank
thank you.
you. Bye-bye.